Good afternoon, everyone. What a great song to celebrate moving toward the best in transplantation for everyone, especially since Tina Turner is a kidney transplant recipient. I'm Jackie Burgess Bishop, CEO of the National Kidney Foundation of Illinois, and it is my privilege to welcome you to the inaugural National Kidney Foundation of Illinois Black History Month webinar. Our mission is to improve the health and well-being, to improve the health and well-being of people at risk for or affected by kidney disease through prevention, education, and empowerment. And we do so through an equity lens. Through the webinar, you will have an opportunity to hear and observe a virtual conversation and presentations addressing the timely, transcending, and impactful topic of closing the gap in access to transplantation for African Americans. We are honored to have a distinguished and engaged panel, including Dr. Velma Scantlebury, Dr. Dinee Simpson, Dr. Milda Saunders, and Samantha Mok. We know the challenges from 2020 continue to follow us into 2021. We are also aware that Blacks are nearly 4 times as likely to develop kidney disease as compared to other populations. NKFI continues to help those at higher risk during this global pandemic. I want to thank Monica Fox, the Director of Outreach and Government Relations for NKFI, and the Planning Committee members for this dynamic program. This program would not be possible without the support of our sponsors. We extend our appreciation to CareDx, Gift of Hope, the Northwestern Medicine Transplant Center, the University of Chicago Transplant Center, and the University of Illinois Transplant Center. Thank you again for your continued support. Please enjoy the National Kidney Foundation of Illinois' inaugural Black History Month program. Thank you.
Thank you, Jackie. And thank you all for joining us. Let's make this program interactive. The chat function is live. That way we feel like we're really together in this virtual reality. I knew this was going to be a great program when we received this message as a reply to the first email we sent out announcing it. This message was from a mother who wrote about her daughter. She said, she began dialysis in 1980 as a 36-pound she began dialysis in 1980 as a 36-pound, 8-year-old at Children's Memorial Hospital in Chicago. She had 4 kidney transplants in 40 years. Her 3rd transplant was in Pittsburgh. Her gifted surgeon was Dr. Velma Scantlebury. A miracle beyond the surgery took place during that period because of Dr. Scantlebury. She goes on to say her daughter has since passed, and she was trying to reach Dr. Scantlebury to thank her profusely for being the human part of a miracle in her daughter's life. Dr. Scantlebury has performed the human side of over 2,000 miracles prior to her recent retirement just the end of last year. I am delighted and honored to introduce her today for this very important program and discussion. She is the first Black female transplant surgeon in the United States of America, and she also happens to be my friend. Introducing Dr. Velma Scantlebury.
Oh, thank you, Monica. Thank you so much. Thank you for that wonderful letter from one of my patients that truly touched my heart. And it's an honor and a privilege to be here today talking about closing the gap and addressing the issues that we have to deal with when it comes to organ donation and transplantation, and looking at the issues of Black and Brown people as they're struggle to get on the list, and talking about the issues of disparities that we're facing in terms of access to transplant, even just knowing how to make the right choices, being given the correct information. And so it's important for us to have these discussions, because we need to be able to bring the focus to the table, address the questions, and educate our communities so that they're more equipped with the knowledge to be able to talk to their doctors, ask questions, and begin to empower themselves to take charge of their health and begin to seek what is in their best interest in terms of optimal care. So today we're going to start our conversation with Dr. Milda Saunders from the University of Chicago. And Dr. Saunders has been appointed as the Assistant Dean for Multicultural Affairs and is also an Assistant Professor of Medicine. So we welcome her and ask her she can also tell us a little bit about herself and her career, as she has worked tremendously in the area of disparities when it comes to access to dialysis and patients on dialysis, as well as transplantation and all the issues that surround us. And I know she only has a short amount of time, but we'll try to allow her to touch base and enlighten us on these issues during this webinar. Dr. Saunders. You need to unmute. There you go.
Okay, thank you. And I want to share my screen. All right. Okay, great. Hopefully that was the most difficult part of the whole time. So today I'm going to take you on a whirlwind talk about racial disparities in end-stage kidney disease and transplant access. And thank you, Dr. Scantlebury, for your introduction. I am at the University of Chicago. I am a general internist and ethicist and the living donor advocate position for our Transplant Institute, as well as a health services researcher. So this is and a lifelong Chicagoan. So this is an area that is near and dear to both my clinical and personal heart. So during our brief time together, we'll talk about what is meant by racial disparities in renal transplant, talk about the existing evidence, and importantly, identify potential solutions at the personal, local, and national. So when we talk about health disparities, what do we mean? So we mean a difference in the quality of care or health outcomes for a non-minority group compared to a minority group. Some of these differences are due to biology or choice, but many of these are due to socially based health disparities, so discrimination in the world, housing, social and educational issues, as well as disparities within the healthcare system, both how the system operates and bias and discrimination amongst providers. And when we think about disparities in end-stage renal disease incidence, we know that racial and ethnic minorities have a higher rate of end-stage kidney disease, and the prevalence for African Americans is about 4 times their non-Hispanic white counterparts, and Native Americans have about double the rate. And then when we look at differences in access to transplant, so looking at the transplant rate for deceased donor transplants, we see for whites that the rate overall is decreasing, and for African Americans, it's been steady to increasing, so that the disparity is actually starting to narrow, looking at the line in red. However, if you look at the line in gray, living donor transplants, we see that while donor rates, access to living donor transplantation has decreased, the disparity between African Americans and whites has actually increased over time. And as we go through the multiple steps to transplant access, being eligible and appropriate, being referred, completing evaluation, being on the wait list, and receiving a transplant, there are disparities at each step of this process. And so an older study saw that comparing white patients who are appropriate for renal transplant to African American patients who are also appropriate at each list to receiving a transplant, there are important disparities for Blacks and whites, so that 92 versus 96%, 85 versus 78%, and African Americans are less than 1/3 likely to receive a kidney transplant in this era. One problem is that patients are not identified or referred. So a recent study looked at how our current evaluation, the race correction in EGFR, how that impacts patients. But it also allowed us to examine how African Americans may face challenges in being identified and reaching appropriate access. So at a single healthcare system in the US, there were 64 patients who were African American who, looking at taking out the EGFR correction for race, they would be reassigned from an EGFR greater than 20 to an EGFR less than 20. So this reassignment is what has a lot of the societies appropriately in much discussion. And we see that 0 of those 64 patients who were reassigned were referred for kidney transplant. So this is why we want to get the staging American patients who were appropriately staged with the EGFR less than 20 had already been referred for transplant. And so while getting it right is important, we see that there are other barriers in access to care. A single center study showed that one of those barriers is completing the transplant evaluation. So a single center study in Chicago showed that about 23% of people did not complete the transplant evaluation in 1 year. And when we look at who those people were, we saw that Black men were less likely than Hispanic men, Hispanic women, and white men to complete their evaluation. However, Black women and white women were equally likely to have challenges completing the evaluation. We also saw that needing more than one test and having more than one hospitalization was also associated with non-completion, which many patients face sort of challenges. And this carries forward when we look at what that means for reaching the transplant wait list. So unpublished work here with our group shows that compared to white men who are this red line, Black, both women and men are less likely to appear on the renal transplant wait list. So are white women and Hispanic women. However, Black women have a double disadvantage. They are less likely than both Black men and white women to appear on the renal transplant wait list. And so what methods have worked to reduce disparities? Talk about patient navigators, culturally sensitive education, patient physician outreach and education, as well as policy changes in tracking, allocation, and funding. So one study in Ohio looked at 23 hemodialysis facilities to look at the effect of a patient navigator. And they found that patient navigation allowed patients to increase twice as many steps, and the effect was similar across race and SES groups. At Emory, they implemented a required educational session for end-stage kidney disease patients who had been referred and looked both pre and post evaluation. And they found that the 1-year evaluation completion rate was higher in the post-intervention group, and the effect of the intervention group was stronger for Black patients and those living in poor neighborhoods, which means that the disparity was not, the quality wasn't just improved overall, the disparity was reduced. Some changes in policy that have also been effective. In 2003, UNOS changed the kidney allocation policy to eliminate the points for HLA-B matching, and this resulted in a 23% reduction in the African American and white transplant disparity for deceased donor kidneys. In 2014, the kidney sort of helping to deal with the challenges people face getting to the wait list. And so that narrowed the actual transplant disparity while the wait list disparity remained. We have future policy level interventions, changing allocation policy, which will happen now, as well as increasing financial support for longer immunosuppression, as well as we can continue to monitor disparities both at dialysis and transplant centers and how we license and pay for our services. So in conclusion, end-stage kidney disease is a high cost, high morbidity disease. African Americans have greater incidence of end-stage kidney disease, lower access to transplantation, and we must continue to examine our personal actions, our institutional practices, and national policies to address these inequities. Thank you.
Thank you so much, Dr. Saunders, for that incredible beginning introduction and a synopsis of the disparities in transplantation. And so I want you to expand somewhat on the EGFR, the 20%, and explain for the audience what that means and why that 20% of kidney function is important.
So we have previously, or currently, I should say, in many institutions, have a race correction for EGFR, so that for a given serum creatinine, when we calculate the EGFR, there's a 1.2 to 1.6, depending on how you do it, increase for African Americans, so that at an given range, we say African American patients have better kidney function. And this leads to people not noticing perhaps a greater decrement or sending people to nephrology, as well as thinking about renal replacement therapy or sending people, referring people for transplant. And so this was thought and is based on some evidence. However, we know that race is a social construct, and we don't necessarily want that to enter into our medicine and our classification and our referral patterns. And we see that that is important, but a small part of the challenges that African Americans face in reaching appropriate care.
And so the importance is that if an African American, by using the EGFR as it stands, will give them a better EGFR, which may exclude them from being able to be listed because it puts them higher than that 20%.
Absolutely. Correct? Yes. And as well as sort of prevents people from doing appropriate education and dose reducing medications. So all of those things are true. Yes.
Absolutely. Now, one more question in terms of the African American woman, and she is doubly disadvantaged. What do you think contributes to that bias in terms of referral or even thinking they're not candidates?
So that is longer than I have here, but I think it is on multiple levels. So some of it is our interpersonal racism. So just our bias about who is considered appropriate. And some of it is structural in terms of all of the things that patients have to do to get through the transplant process, all of the tests and the studies. And we know that Black women are caregivers for their families and their communities, and may face real challenges in making all of the appointments and in perhaps showing appropriate social support to get through the transplant process. And so there are multiple interventions that we need to correct that.
Absolutely. There's so much that we can discuss and talk about in terms of those barriers. And I'm glad to see that the implementation of those in terms of interventions to how do you mediate people through the list and get them to complete their all the criteria that they need to do in order to get listed. That has been quite a delay for many people who can sit on the list for a year or even greater waiting to get listed because they're very slow or are not able to complete the multiple tests. We know that one of the issues that we face and is in terms of is also for the multiple aspects of having to lose weight, get all these multiple tests down, cardiac tests and all those things delay patients in getting through the workup process. And we know that's a challenge. So we appreciate your outline all these things for us to think about. And I thank you so much. And we'll move on to our next speaker.
Thank you so much.
I appreciate all your input, and you guys write your questions down, and so we can have them in the chat for discussion later on. Thank you. Our next speaker is Samantha Mok, who is an outreach coordinator, has experience both in terms of being a solid organ transplant coordinator, as well as a dialysis nurse. And so she has vast experience, and we know that we'll get through the process of getting on the waiting list has to do with weight issues and the opportunity to figure out how they're going to lose weight, being referred for many different modalities. And so we will ask Samantha to introduce herself, give us a little bit about your background, and begin to tell us what you're going to focus on today.
Thank you for that introduction. My name is Samantha Mok, and I'm currently a transplant coordinator for the University of Illinois at Chicago. I'm a social worker by trade, and I have some dialysis experience, but most of my career has been transplant social work definitely in urban areas, St. Louis and Chicago, for sure. And I will, thank you. Okay, so my presentation today is about Black patients in obesity and kidney transplantation. Next slide. So probably against my better judgment, I crammed in 4 objectives into this small speech, but small speech, but I didn't feel like I could talk about one thing without talking about the other, So quickly, the first objective is to understand what obesity is and how it is measured. The second is identifying contributing factors to obesity in the Black community. And then to understand how obesity limits kidney transplantation as an option in the Black community. And fourth, to understand UI Health's approach to obesity and kidney transplantation. Next slide. So I thought I would give a little bit of context and some numbers just for reference for the talk. First, Chicago's population is over 2.7 million people. There are a lot of people here. Black people make up about 81,000 of Chicago's population. About 35% of Black people in Chicago are obese, and sadly, nationally, Black women have the highest rates of obesity. There are 3,300 people listed for a kidney transplant in Illinois, regardless of race. 40% of people listed on the transplant list for kidneys in Illinois are Black, and so you can tell that Black people are overrepresented in that number. 25% of Black people listed in Illinois have a BMI of between 35 and 50. And I think that, and I know that a BMI of greater than 30 is obese. So there are over 25% of the Black people listed on the transplant list for a kidney in Illinois are obese. And that's compared to 19% of all ethnicities. Next slide. So obesity is the World Health Organization, the WHO organization, defines obesity as an abnormal or excessive fat accumulation that may impair health. The standard way, I think, of measuring body mass index, I'm sorry, I don't know the exact calculation, but we're all familiar with, you can Google the calculator and you can put in your height and your weight and then wait for a number to come up on the screen that'll make you cry, and then you move on with your life. But there's the body mass index is the standard way to measure obesity, but there are downfalls to that because it doesn't tell you exactly where the fat is on the patient's body, and it doesn't take muscle into consideration, and muscle weighs more than fat. So I'm sure most transplant centers also measure abdominal girth and take that into consideration as well. And this obesity, of course, is a problem because excess weight means that you are more likely to have or to develop diabetes, hypertension, cancers, sleep apnea, or other medical issues. And we know that diabetes and hypertension are 2 of the main culprits in our community. Next slide. So contributing factors to obesity in Black communities. This is by far a very abbreviated slide. I feel like this could be a talk on its own and researched on its own. but I wanted to talk about a few. Poor diet may be common sense, but poor diet is a contributing factor to obesity in our community. And I think that it's important to talk about food deserts and food swamps, which I'll talk about a little bit in the next slide. Excessive caloric intake, again, it might seem like common sense, but I think that it would be dangerous actually to talk about excessive caloric intake and not talk about mental health, especially in the Black community. Limited physical activity, again, may seem simplistic, but I think it would be erroneous to not talk about safe places to exercise, especially when you're talking about physical activity in Chicago, in the Black community. And then there are a host of socioeconomic factors that you can talk about as contributing factors. Targeted marketing, I think, is really interesting, but also poor access to healthcare, low incomes, and more. Oh, next slide. So food deserts and swamps. So a food desert is an area, a geographical region, a neighborhood that has a lack of access of affordable, healthy foods like fruits, vegetables, whole grains, things like that. In Chicago, food deserts are primarily situated on the south and west sides. And I do have a poll. I hope that you can set up the poll. Does anybody know what percentage of the Black community lives in the south and west sides? Tell me. I'll just take 2 seconds. All right, so I won't take two, there you go, everybody knew. Okay, good, 70%. 70% of the Black community lives on the south and west sides. And again, that is where the majority of the food deserts are in our city. One of my colleagues, Veronica Thompson, is a dietitian. She's a transplant dietitian and a dear friend. And she did this really wonderful study about CKD patients and African-American patients that we had at UIC. And she was trying to figure out if where they lived had anything to do, in food deserts, had anything to do about with their obesity. And she found that African-American kidney patients, pre-transplant patients at UIC comprise the largest group by race living in food deserts of our CKD patients at UIC by 25%. So I think that that's striking. At the same time, she did show that low income status was shown to have a stronger relationship with diet, hypertension, and CKD than residing in a food desert. But I think that if you ask more questions and look at it in a different way, you can see that those two things are probably, they're probably married. And food swamps, I wanted to just touch base on. That was a new term for me, but food swamps is an area with a high density of establishments selling junk food, basically. And again, I think that if the answer, is somewhere meshed in between all of those explanations. Next slide. So obesity and kidney transplantation. So this is an issue because the larger the patient that is seeking a kidney transplant, the higher the incidence of infection, delayed graft function, delayed kidney function, or longer hospitalization. And when you have a longer hospitalization, that can just lead to a whole host of other problems. I found that 4 out of the 6 transplant centers in Chicago have BMI restrictions less than or equal to 40. 2 centers, UI Health being one of them, in Chicago don't have any BMI restrictions. And of Black patients currently listed, 25% have a BMI between 35 and 50 in Illinois. And I'm sorry that I couldn't get more granular data, but I think that statement still is clear. It shows that there is a huge chunk of Black patients who aren't even eligible to get a transplant at most of the transplant centers in our city. Next slide. So UI Health's approach, Dr. Benedetti, Enrico Benedetti is our chief surgeon, and he and his team have done a lot of research in terms of the robotic technique and robotic transplantation. He and his team found that using a robotic approach reduces the recovery period after transplant. decreases the number of wound complications and surgical site infections. Because of this, again, we don't have any BMI restrictions at our center, but if we do have a patient that has a BMI over 50, we do require that they have bariatric surgery, which is usually a sleeve gastrectomy. And I looked at the data, and across ethnicities, regardless of ethnicities, about 1 to 2% of the patients listed for a kidney transplant in Illinois have a BMI of greater than 50. So we're not talking about a huge number of patients in that category. We refer patients with a BMI greater than 35 to bariatrics, but that category of patients can decline. Most insurances say that if you have a BMI greater than 39.9, you automatically qualify for, the patient would automatically qualify for a bariatric surgery. If the BMI is less than 39.9, the patient must have 2 comorbidities, high cholesterol, sleep apnea, something else, in order for their insurance to pay for bariatric surgery. And within the last couple of months, this is my final thought. The last couple of months, UIC started doing a panicolectomy, at the time of transplant, which is a surgery that removes excess skin and tissue from the lower abdomen. The thought is that if you reduce the size of the abdomen, that you will reduce the recovery period for the patient, the number of wound complications and surgical site infections. So next slide. So that concludes the slide. I'm sorry it was so fast. I hope it was clear, concise, but clear as well.
Thank you so much. Appreciate your presentation. It does shed some light. I think they're one of the concerns that we have in terms of, our patients coming forward. There's so many who may not get referred just because their primary doctor or the nephrologist may feel that they are all of the criteria for transplantation, or feel that there are many other issues, especially the Black women particularly. But so it's actually wonderful to see that there may not be, there are programs who would allow patients to come forward and with the recommended surgeries. What percentage of patients would you say opt to just perhaps do it on their own?
I think everybody. So I did work as a transplant social worker for a while, and even if in my social work eyes, or if the attending nephrologist says, I don't think that this is this patient is a candidate for transplant for X, Y, and Z reason, I think it's important for the mental health of the patient to go ahead and get referred and have, a clinician specialized in transplant tell them yes or no. I think that, that just means wonders. And especially in a city where, in Chicago, we have 6 transplant centers, so you can really shop around here. And I think that, for lack of a better term. So I think that it's important. I really, really stand by that. I think it's important for the mental health of the patient to be able to go and do what they need to do and advocate for themselves.
Now, for those patients who opt not to have the surgery, is there a plan in place or a program that allows them to say, we will work with you to help lose X amount of weight over this amount of period before being listed, even if it's inactively, until you get to that point?
Absolutely. So our center has 2 transplant dietitians, Veronica and Catalina, and they work hard at giving a plan. The first time that they meet a patient who is overweight or obese, they make a plan for the patient to lose the weight. I mean, it's good for everybody to have a healthy weight, regardless of whether or not you're trying to seek a transplant or you decide not to, or to have a transplant. So we do have that. And UIC also has an exercise study. Frailty is a big issue with transplantation now, with populations getting older and everything. And UIC does have an exercise program for people who are waitlisted or thinking about getting on the list.
Awesome. Thank you so much.
Thank you.
We now have a question. What are the reasons for not being able to have a transplant due to obesity? It was not clear.
Okay. I'll do my best, and maybe one of the surgeons can jump in. But from what I understand is the larger your abdomen, the more likely you are to have surgical site infections, wound complications. I think it all centers around wound complications. And so it's preferable that you have, especially if you're not doing robotic, that you have a smaller abdomen to avoid all of those complications. Somebody
and also, yeah, absolutely. And I think sometimes it's a matter of saying, in terms of if your BMI is very high, then you have to somehow think about what is this kidney? Is this kidney going to overwork, or what we call hyperfiltrate, because it's going to work very hard to be able to accommodate the large body mass and the large blood volume. And some patients have what we call secondary disorder of kidney disease based on obesity. So we want to protect that kidney. And also the anesthetic risk it can be in terms of putting that person to sleep, making sure that there are no breathing problems, all those kind of things. So it's about the safety of the patient, but we also want to make sure that that kidney can also survive and do well long-term from that standpoint. Thank you so much. I think we have some videos to show and also some short nutritional videos. So we'll pause for that while we get these videos in. And thank you so much, Ms. Samantha Mok, for your presentation. Thank you so much. Do we have another video to show us? That it makes me hungry. I think I want to be able to go make that air-fried cauliflower. I want mine a little spicier, so be sure to put that recipe in the chat so we can all get it. Okay, I hope everyone have that hot sauce recipe. I might have to look for my Pepsi before I try that one. So looks good. Thank you so much for those recipes, and delighted to try them myself. So we'll move on to our last speaker, which will be Dr. Dinee Simpson, who is the first Black African-American transplant surgeon in Chicago, and doing a wonderful job there. Dr. Simpson, you're going to tell us a little bit about yourself and your outstanding program, reaching African Americans and providing all the necessary information that they need to get transplanted, to educate them, to begin to have all those early discussions about how to get listed and how to avoid all the pitfalls. So Dr. Simpson.
Thank you very much. I am so honored to be here and speaking with these wonderful women. This is really fantastic. I'm going to share my screen here. Let's see here. And share it. Okay, I'm going to get my presentation mode. Excellent. All right, so as Dr. Scantlebury said, I'm Dinee Simpson. I am an assistant professor of surgery at Northwestern Medicine, and I do transplant surgery. I transplant livers and kidneys, and I am the founding director of a program that we call the African American Transplant Access Program, and throughout my talk here, I'll call it ATAP for short. So, you know, what I decided to talk about is why we need to have a comprehensive program. You know, Dr. Saunders highlighted that, you know, in the medical literature, there are a number of papers that describe interventions to help Black patients navigate the transplant process and get listed and transplanted. So why did I need to create a program? And so I'll tell you the reason that this idea grew inside me was first based off of observation. And this goes back to when I was a trainee, where my observations, which are listed here, is that when we were in our transplant clinic, you know, the first day I was in transplant clinic, I noticed that every single patient was Black, and that just astounded me. And, you know, I also noticed that the patients who were arriving for transplant evaluation tended to be arriving much later in their disease course compared to people who weren't Black. And then I observed as they navigated this process, they struggled with getting listed for a variety of reasons. And then the last observation that I made as a trainee is that of all the living donors transplants we did when I was a trainee, not a single one of them was a Black patient. And so these observations drew me to the literature. I thought to myself, gosh, there has to be something written about this. And lo and behold, there was. The literature, the medical literature is full of descriptions of disparities, thousands of papers dating from, whoa, did my slides just advance on their own? That's interesting. Hold on just a second. Okay. On their own, let me just get back to, I can't control my slides now. This is bizarre. There we go. Thousands of papers describing disparities for African American patients, and not nearly as many describing interventions. And so there seemed to be kind of a mismatch there. And when I arrived here in Chicago, I decided that I would start a program, and this little picture here on this in the slide here shows our website, where what I've done is I've gone to literature, I've seen all the barriers that affect Black patients as they try to navigate the process, and we've compiled several interventions into one comprehensive program. So we're not taking a single pronged approach, we're taking a multi-pronged approach to help shepherd our patients through the transplant process to get them listed and transplanted. Now, again, my process started with observation, but as I said, I went to the literature. So I wanted to share some of the literature here. Luckily, both Dr. Saunders and Ms. Mok have shared a lot of this data with you. So some of this is redundant, and you know, we didn't converse when we prepared our presentations, but there's a lot of synergy between the three presentations. So I think that that's really good to have that repetition. But the points that I included here are just some of the points from the literature. Black patients are less likely to be referred to a nephrologist prior to initiation of chronic dialysis. They're more likely, oh gosh, why is this happening? They're more likely to be referred at advanced stages of kidney disease. They're less likely to complete a kidney evaluation to be listed, and they're more likely to have, or less likely, I'm sorry, to have access to living donor transplantation. And as I said, the list goes on. These are just some of the disparities that exist. Now, as both Dr. Saunders and Ms. Mok told us, you know, kidney disease is, you know, very prevalent in the United States. It affects over 30 million Americans. It's the #9 leading cause of death. And even though African Americans represent 13% of the population in the US, we represent 35% of those suffering from kidney disease. And we are 4 times more likely to develop kidney disease, as was discussed earlier. And so I just want to quickly take you on a little bit of a slide tour of Chicago that explains why some of those these disparities in these numbers exist. You know, I think that one of the most common pitfalls when talking about why Black Americans are more likely to suffer from kidney disease is people tend to think, well, gosh, that has to be genetic. And although genetics play a role, they do not play the predominant role. And a lot of this is explained by the social determinants, as Dr. Saunders highlighted. So let us first look at this one slide, which is a map of Chicago. The next few slides will be a map of Chicago. And so if you look at the slide on the left, you can see this is an early slide from May of 2020, showing where the hot spots for COVID wasn't so hot at the time. Again, this is data from May, but this was eye-opening. This is when people started to think, hey, wait a minute. You know, there's a disparity here on who's getting COVID and who isn't. The later slides, which I haven't included in this presentation, are showing now who's dying from COVID and who's getting vaccinated, and it's the same distribution. If you look at the right, this is a map of Chicago, and just like we saw in our poll, you know, the blue dots represent the Black population in Chicago, and they are clustered on the south and on the west side. That is where the majority of our Black and brown communities lie. I want you to keep those locations in mind as we move through the next slides. Now, Ms. Mok talked about food deserts. Chicago's food deserts are nearly exclusively African American. You can see here the light brown shows where our food deserts predominate in the city. This picture here on the right shows a Dollar Tree and a DaVita dialysis center in a shopping plaza where these two centers used to be a grocery store. And this is the story for many communities across our city. I learned a new term today, food swamps, from Ms. Mok, and that is also applicable to these very same areas. Not surprising then, when you look at CDC data, that these same areas on the west and the south are hot spots for hypertension or high blood pressure and diabetes. This data comes from the CDC. You can look at a number of other illnesses by zip code with the CDC data. I chose these two because this is the top 2 causes of kidney disease. Therefore, not a surprise when you look at the slide here on the left that chronic kidney disease is also heavy in the west and south side of the city. And then this slide here, which came from our strategy group at Northwestern, shows in the blue dots, which sadly don't project very well, but the blue dots represent dialysis centers. And you can see that dialysis centers predominate in the south and west as well. Yet the red squares, which represent specialty care, specifically nephrologists, are lacking in these areas. So these areas also represent specialty deserts. And then my final map slide shows life expectancy in Chicago. And so sadly, when you look at the South and West, you can see that life expectancy is lower than our affluent white communities by almost 30 years. And so that is certainly attributable to the social determinants in the previous slides that I showed you, the lack of resources and the underserved communities. So with that data, I created the African American Transplant Access Program, and with the following vision and mission. We want to enable our community through awareness, access, and advancement. So our Transplant Center has committed to a campaign to eliminate disparities for Black residents of the greater Chicagoland area in relation to transplant care for kidney and liver disease. We are dedicated to the development of a deeper understanding of the historical barriers and cultural concerns of the African American community and strive to work together with the community to overcome these obstacles. And so through our program, we're aiming to increase awareness, to improve access, and to provide excellent outcomes through community engagement, participatory research, and patient and provider education. So my final slides will just highlight a little bit of how the program is structured. we have currently, and I am, I am aware that this is an evolving landscape and that our program will likely expand and change with time, but currently we are focused on 4 pillars for the ATAP program. The first pillar is trust. We know that for good reason, distrust is a major barrier, not just to transplantation, but to good healthcare overall in the Black community. And we are aiming to change that. We need to re-earn trust from our Black community. And so there are a number of ways that we go about that. There was a question that came through earlier about, do we feel that our race impacts the relationship that we have with our patients and their ability to navigate the transplant process? Absolutely. There is data showing that patient-provider racial concordance, so a patient and provider having the same race or cultural background, really makes a difference when it comes to trust and to that forming that important relationship that will help the patient to navigate their process, whether it be transplant or otherwise. And so trust is a major pillar of the ATAP program. Cultural competency is very important. We need to understand and respect the culture of the patients that we're looked to serve. All of these, the reason why I drew this in a continuous circle is because all of these are intertwined. All of these affect one or the other. Cultural competency helps to build trust. And we have health literacy and diet. As Ms. Mok spoke, obesity is a major barrier to transplantation. And likewise, understanding the cultural preferences, food preferences of our multicultural patient base that we serve. It's not just Black patients, but we have Hispanic patients, we have Asian patients, we have Indian patients, and we all have different food preferences which are impacted by the highly restrictive diet, the renal diet, and if you're looking at liver disease, the liver diet, cirrhosis diet. And so we need to understand that and work with our patients to help them to still enjoy the foods that they grew up enjoying, but be within the of this restrictive diet. Hand in hand with diet, I believe very firmly, is health literacy. The literature will show us and it will tell us that poor health literacy is very common among those with chronic kidney disease, and it disproportionately affects people who disproportionately affects our Black patients with chronic kidney disease. And then finally, psychosocial barriers. We as a transplant community will require a lot of our transplant patients to, get through the hoops to get listed. That can be anything from insurance requirements to social support requirements. There was a question earlier about, why Black women were doubly, affected when it came to listing. And the observation that Black women are caregivers is spot on. I had a patient who cried and told me, I care for everybody, but now I have no one to care for me. This is a common scenario. So we have a dedicated social worker to the ATAP program who is also racially concordant, Ms. Shamir Harrington, who has done wonderful things to be very creative to help find support for our patients as they navigate this process. Many of our patients are essential workers, or their family and friends are essential workers and can't afford to take off time to be that 24-hour around-the-clock support. So we got to find ways to work around that. That should not be a reason that a patient is eliminated from the transplant process. So finally, I believe this is my last slide. I'll just talk a little bit about the early outcomes for the ATAP program, of which I'm very, very proud. ATAP has only been around for a little under 2 years. We haven't been around that long, but we've already seen tremendous gains for the program. And so these numbers are constantly changing. We have had at this point over 50 referrals. 34 of those have been evaluated. That number has even changed. 18 have been listed, 11 have been transplanted. If you look at the numbers at Northwestern comparing 2017 to 2019, right after the ATAP program started, we saw a 55% increase in evaluations of our Black patients and 18% increase in listing of our Black patients, which I think is very important and something that we're very, very proud of. What's also important is that, this is a continuum. So I don't know what's going on with the slide presentation, but that's okay. We, even though we haven't listed everybody who's been in the evaluation process, we know that many of them are still in the process of being evaluation and can be listed at some point in time. Those who aren't eligible to be listed, many of those reasons are modifiable reasons, meaning things we can change in the future and help them to become transplant candidates. And so I'm going to end here. I know that Dr. Scantlebury wanted to talk with me some more about maybe some of the success stories and answer some questions.
Well, thank you so much for that outstanding summary of your program and the incredible work that you're doing. And I hope that maybe other centers can model take your model and use it to the success of getting those patients who are living in those areas and who may be turned down just because they don't have the social support or they're unable to navigate the transplant process. So what you're doing is truly to be commended and incredible. And so tell me about the patients that get referred to you. Are these patients who are declined from transplant listing or just those who may have, who they perceive to be, well, this is going to take you a long time to get through this process?
We have a whole variety. We certainly have patients who have been turned down at other centers. I would say that is a significant proportion of our patients, and patients who come with very challenging, either social situations or a variety of health conditions that might make them high risk for transplant. So that is certainly part of our cohort. We have another group who never, ever even entertained the idea of transplant. Many may ask, well, gosh, if your program has only been in place for a couple years, how have you already transplanted 11 people? We all know that in Chicago, the waiting time tends to be upwards of 5 to 7 years. Well, that's because a number of the patients who come having been on dialysis for 11 years, 12 years, 15 years, if you can believe it, and were never interested in transplant until they heard about the program because of distrust. So we have patients who come forward from a number of different backgrounds.
So do you think being a person of color has really been instrumental in making this program work?
Absolutely. I absolutely believe that. I think, the number of times that a patient may not even be my patient, may not even be here for a transplant, just walking through the hospital, will grab me by the arm and say, oh my gosh, are you a doctor? Because they recognize my white coat. And I've never seen a Black doctor before. Doc, I'm so proud of you. In my first interactions with patients in the transplant clinic, and this is what pushed me down the path to create a program like this, was when I was a trainee. And, as I mentioned, every single patient that we were evaluating that day, was 6 patients, were Black. I had patients cry, I had patients hug me and tell me that I did so much for them, and I hadn't done anything other than walk in the room looking the way that I looked, So I do think that it is very impactful. I think it really helps to start to rebuild that trust.
Absolutely. And I can tell you, as also an African-American transplant surgeon, it is really gratifying when you feel that you really have your presence matter. You've made a difference in the life of your patient in being able to say, I know you're here for me. And so many patients have, like you've said, have said that in terms of, I wouldn't have come forward. I'm so glad that you evaluated me and gave me that chance to be able to get my foot in the door. So I applaud your program. It's an incredible, and we need to do more of that, because patients need to be able to say, I trust my provider. I trust that they're doing the best for me. And we haven't even touched on living donation and the impact of helping our people of color navigate that living donation process and being able to say, I can help you do this, come to us, we can be that force to guide you in the right path. So thank you very much, Dr. Simpson and Samantha and Dr. Saunders. I appreciate your presence here doing this tremendous program and all our efforts to close the gap. We need to do more of this. We need, now that we have the ability, we may not be able to come together, but we can have these conversations endlessly. So thank you. And I turn it over to Monica. Thank you so much.
Thank you so much, Dr. Scantlebury. I know you have to run. Wow, 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 wow. let's hear it in the chat. Guys, let me know how you felt about this program. I can just say this was absolutely amazing. These presenters are just awesome. The work that they are doing is just, anybody who knows me, you know how passionate I am about kidney disease and transplantation. And yes, Elisa says she feels inspired. Roxanne Smith says, excellent presenters and content. Every aspect addressed, wonderful and informative presentations across the board. Thank you all so much. Thank you for those comments. This has been amazing. I want to thank our presenters. I want to thank my committee who worked with me to the bitter end. It takes a teamwork to make the dream work, I always say. I want to thank our fabulous sponsors, CareDx, Gift of Hope, Northwestern Medicine, the University of Chicago Medicine, and UI Health, all those 3 transplant centers. Yep, so I want to thank those sponsors, and I want you to be sure to check out our sponsor resource page, which is, we sent out the link. We put the link in the chat. We'll drop it in the chat again, but it also was included in your reminder email that you received this afternoon at 3 o'clock. I also want to encourage you to follow us online. You can find us on Twitter, Facebook, Instagram, YouTube. And finally, if you want to know more about Dr. Scantlebury and her story and how she started out as a little girl in Barbados, check out the Journey Continues podcast. She was the one that was my guest on the episode that came out on, let's see, the 2nd of February. So the Journey Continues podcast is available on all podcast platforms, and you won't be sorry if you check it out. And definitely you can learn a little bit more about the personal side of Dr. Scantlebury and how she how a little girl from Barbados became the first Black female transplant surgeon in the country. So that's it for us today. Thank you guys so much. Thank everyone for joining us. Thank Jackie Burgess Bishop, our CEO, for her incredible leadership and guidance and vision and allowing us to do creative and important, interesting programming like this. So thanks for joining us, and everybody have a great evening.